cool method.
Okay.
Just get a stick or something.
Yeah. Yeah, we're good.
It's all good. There won't be that much.
And Boris will be here in a minute.
And Misha, as far as like questions and stuff, or if you guys need to wrap up.
And then you can push this to turn it off.
Oh, okay.
You can just like on, off the red and green.
So thanks everyone for being here or online. We're going to walk you through some preliminary data from a contract that our group has with the FDA. And we're going to talk about some of the methods and work we've done to develop this work over the last couple years through this collaboration of a number of investigators at UCSF who are in psychiatry, neurology, emergency medicine. And we've really kind of formed this team that's come together around what we have been trying to do as a novel approach to understanding the community uses of psychedelics and safety. Let them kind of get that up. So just to start, disclosures. So this is my slide. You can see the government or university funds that have supported my work, as well as philanthropy. We are going to talk, of course, about non-FDA approved uses of some substances, and I'm a signatory to the Statement on Open Science and Open Praxis with Psychedelics, which is an interesting document from the field from a few years ago, talking about IP and use of substances that have been around for quite some time. These are Juan Carlos's disclosures as well. Government and research, government and university funding for his work. This is a slide I tend to include in my talks in the disclosures section. I'll just briefly say I wouldn't do the work that I do today had I not had the opportunity to learn from the people with real expertise of how to use these substances safely in traditional or non-medical settings. I've had the opportunity to learn a lot and see a lot over the years, and so I'm just thankful for that, and I just want to acknowledge that. And if we have an arrow, there we go. Okay. So we're going to talk about methods and findings from observational protocols in this contract that we have, the CUPS project. This involves some ethnographic and survey data. We're going to spend most of our time on epidemiologic data that Juan Carlos will tell us about, specifically about the use of psychedelics in non-medicalized settings. So we're not talking about clinical trials. We're talking about use out in the real world. And really our work trying to figure out the potentials and limitations of understanding safety signals in these settings. So why would we study this? This is a slide I've actually used for a long time when giving talks like this to talk about things that are common or that can happen, even though they're rare when people take psychedelics, things like headache, insomnia, HPPD or hallucinogen persisting perception disorder, behavioral emergencies. These things can happen, but for a long time, this was kind of the best I had to describe what are possible adverse events with psychedelics. The literature has really kind of progressed over the last few years. I often encourage people, if they haven't read it before, to read Rick Strassman's review from 1984. It was one of the more sort of extensive reviews of the older literature from the 50s and 60s, as well as up until the 80s, of adverse events that can happen. There's this sort of pivotal paper from 2008 from the Hopkins team that describes their method, this sort of approach for safely administering hallucinogens, as they called them back then, in a clinical research setting. And this is kind of what we had for a long time to talk about what are the risks and how do we mitigate them. There were other sort of observational studies and some reviews. And finally, just this past year, the team at Hopkins published a systematic review and meta-analysis looking back at really, hundreds of publications, thousands of participants to understand what do we know from the clinical trial context about adverse events that happen when people are administered psychedelics. And unfortunately, this kind of our best paper to try to summarize that clinical trials context data is that the evidence is actually pretty poor, the quality of it. And yes, there are serious adverse events that lead to hospitalization, death, persisting morbidity. However, these are rare. And yet, even if we scour the published trials with healthy volunteers and participants, not everything is there. And so I like to point people towards this as an example. This is a blog published by Harvard Divinity School a couple years ago, where a participant who received psilocybin in a FDA-registered clinical trial here in the United States had a rather severe, persisting adverse reaction to the drug that wasn't really documented in the publication. And so years later, she ended up writing about it, wanting to get news out there that it's not quite as rosy as it looks from the papers. And she even talks about how when she reached out to the study team, they kind of said, no, that can't happen. That can't be due to the drug. No, this is, it was really hard for her to find help in dealing with these symptoms she was having. And so this is just one example of how what we read in the systematic reviews are missing parts of the story sometime. Now, focusing on this because, as many of us know, the field of psychedelic medicine really kind of took off in the last 5 years, definitely started picking up 10 years ago, but in 2020 I feel like there were papers and companies and a lot more studies coming out. But in that year is also when we started seeing things kind of, I don't know, not escape from the lab, because they didn't come from the lab. These substances have been in the community, but this is when we had Oregon psilocybin services get approved by voters to be stood up in the state of Oregon for adults without diagnoses to take psychedelics in a state legal way. It was also at this time, given so much of the excitement and the hype of what was coming up in 2019, 2020, that I and two of my mentors, Alicia Danforth and Charlie Grobe, started having lots of conversations with people in the field and having some concerns about how quickly things were moving and how much people were focusing on the benefits but not talking about some of the safety issues that many of us knew from what we had just seen in the community and other settings can happen. We wrote this commentary, which is a very sort of brief summary of some things we were thinking about then. Some of these conversations did involve folks in the federal government, and so I also point people towards this paper published in 2022 that came out, co-authored by members of SAMHSA, this Substance Abuse and Mental Health Services Agency of the U.S. federal HHS, where not just us, but many others at this time were starting to get this conversation of harms, and particularly use in community settings, and how we can sort of get ahead and try to prevent things from happening. But I will say, even when we published like this commentary, we tried to send it as a perspective piece. I think it was to JAMA Psychiatry, and they said, yeah, but where's your evidence? Like, we get it, like this all makes sense, but like where's the, actually we were trying to follow your perspective piece. We wrote it as a response to what Boris wrote, and we were like, well, we want to do one of those too. And they said, yeah, but you don't have data to prove that this stuff is like happening. And I was like, oh, this is terrible. So we said we need to get some data and look at that. Something else happened in 2020, COVID. As an emergency department psychiatrist, I actually got very little research done that year. I was in sort of our trenches down in the mission for like most of the week, most of the year. One positive outcome is that I got to really know and get to work with Juan Carlos. So as two emergency room physicians, like an actual emergency room physician and then a psychiatrist ED physician, sharing patients, just talking about things, staying up late at night on the night shift, talking about the work that we do, toxicology, mental health, substance use. We said we should write a grant, and so we did, and that's the work we're going to talk about today. So somehow the FDA, which has an extramural funding arm, put like one line in this regulatory science contract they put out an RFP for every year, saying that they'd be interested in data not just on alcohol and opioids and other substances that cause harms, but also psychedelics. Someone got that in there. And so seeing that, we decided to put together a proposal that would be a multi-method approach to understanding harms in real-world settings related to psychedelics. We put together a large team. This is like a 150-page proposal. It took quite some time. These are all of the investigators that went in on doing this. My co-PI, Jenny Mitchell at UCSF, and I submitted this with our colleagues. And the idea was that we would come up with a series of protocols that were all community-engaged forms of research that used a combination of qualitative and quantitative methods to try to really understand empirically what are the risks of psychedelic use outside of the lab or the clinic. The idea is that this data could be helpful for communities that use these substances, clinicians, researchers, and policymakers, as we were seeing Oregon and other things coming down the pipeline. There were 4 initial protocols that we started working on. CUPS-1 basically was a community-based participatory research study where we partnered with long-standing entheogenic or psychedelic churches in the United States. So these communities have to be operating in the country for at least a decade, where we talk to them about safety problems or safety practices that they've developed. CUPS-2 was another way of looking at set and setting. So we went to people with substance use disorders seeking recovery or in recovery who were using psychedelics in conjunction with 12-step recovery groups like AA, and how they were coming up with ways to use these substances safely in that setting. CUPS-3, Juan Carlos will talk about, which is our sort of epidemiology focused arm of this. And then we had another project actually, which was based with colleagues in Brazil, that started setting up a large international survey of ayahuasca users and looking at neuropsychiatric sort of batteries amongst that community. That project I'm really proud of, even though it was really hard, because there's so much work that we were basing our studies on that have come out of Brazil for the last 20 years with some really excellent investigators who have like no access to funding compared to like we had, and so it was like a pleasure to get to write that into this grant with them. And we did this because we wanted this to be community-engaged science. We actually formally partnered with an education nonprofit called Chikern Institute in San Francisco to do some education, outreach, dissemination of results in the contract. Today we're going to focus just on these, the epidemiology part, and then towards the end, if there's time, we'll kind of briefly get into some of our qualitative findings. But with that in mind, keep this question sort of front and center, which is, how can we meaningfully assess psychedelic-related adverse events in real-world settings? Meaning, like, methodologically, how do we really like sort of make sense of this, interpret this, and understand what we're seeing when we try to measure this, given the complexities of getting this data and understanding what it means? So with that, I'm going to pass it over to Juan Carlos.
Thanks, Brian. And thanks, everyone. Thanks for having me. I'm excited to be here. I remember 22 years ago sitting in this seats for the first time. So it's awesome to be here and talking about this. So yeah, with a couple of things that Brian mentioned in mind. One, he said, this didn't escape the lab. These are substances that have been out there. And two, thinking from the FDA's perspective, right? We all know about phase 1, phase 2, phase 3. You can think of this as a phase 4 study, but it's a little more complicated because who knows what someone actually used? How do you track what was sold? How many doses? What was the dose? So many things that complicate it. So it's not just a usual phase 4 study. So what we've done is try to come up with several ways of answering this question that altogether can paint a good picture of what's happening. So some of the aims were even just to create the data sets, some of which are off the shelf and some that we developed ourselves, and to look at these as proxies or as measures of use and also harms, and to tie that together with changes in policy. We wanted to look at, are the clinically significant events, the things that we can observe, and how do we observe them? We went to things like emergency departments, psychiatric emergency visits. Do those change as a matter of policy? Meaning if Oakland decriminalizes or deprioritizes psychedelics, do we see an increase in use? Do we see an increase in visits to the emergency department? And so on for other places. Brian had the good forethought, though, to say, hey, Oregon is having a major policy change. Let's take advantage of that. So first we wanted to look at how policies changed over time, looking at the incidence of these related events in that place around that time. You have a question?
Yeah, you're drawing a line, and maybe we'll get into this, about emergency room visits. Like that's, I think we can all agree, an adverse, like you shouldn't be in an emergency room typically. There's a broader debate, I don't know how much you want to engage with it, of what
Yeah, that's a good point, and this is really what we can observe from some data set, because we will never know from Brian and I, no matter how hard we look, what happened to someone if they kept it to themselves, or they told a family member, or a therapist, or a physician, but it doesn't make it into a chart. So what we're really relying on, and this is one of the limitations, is what we can observe from records.
Or, well, Carlos, one comment on that. Like, great point, Boris. Like a limitation of what we're trying to do, make an assessment at the community or population level, is something that we can measure reliably. And so I think psychedelic-related harm is much more likely in like if you're going to detect it in the medical setting, it's going to be people going to like outpatient visits. I'm having this persistent problem, it's anxiety, trouble with sleeping, my mood got worse, etc. Maybe they are having sort of like some difficulty with reality testing if in like the worst case scenario. But that's much harder to measure at like a first pass when we're even just trying to say like, let's develop a system that we can more with confidence understand like the sensitivity and specificity of what we're seeing. And that's like a real clear signal of harm. So we're starting there, acknowledging that that's probably not what most of the harm could be. And that this is probably going to be just really rare. But how do we even just start with that was our sort of our logic.
So we mentioned there's these natural experiments, right? A place changes their policy from the regular old, these drugs are illegal to this is deprioritized or decriminalized. And so ideally, we'd have two locations that are very similar. We have before the policy change and after, and we use this as a natural experiment. This is what we were hoping for, and as we get into this, I'll explain why we can't exactly do this for all of the data sets we're looking at, but this is the framework that we have in mind, because we can't randomize community to different policies, let alone randomizing an individual. This is just taking advantage of these natural experiments. So local policies definitely have changed over time. Here's a map from Psychedelic Alpha where they've tracked all these different types of regulatory changes. So from legalization in Oregon or Colorado to reduce penalties, and yellow is interesting. These are places with active legislation. Might not have passed, but they're discussing it. This really shows how this isn't localized to just a couple of places. This is really happening all over. Oregon is early, and so we're developing and refining the system to track these events for Oregon, but we're hoping that the methods that we're working out as we go will be applicable to California or other places in the future. This is a sketch of what happened in Oregon. So the brief story is that in November of 2020, voters approved two measures. Measure 109, Brian mentioned, is the establishment of psilocybin service centers. They gave themselves 2 years to sort out how these would be regulated, how people would be licensed, how they would track this, and so on. So it was voted in 2020, but it didn't go live until this regulation you see there in January 2023. In the same November of 2020, they also approved a massive change to all drugs and decriminalized. And so decriminalization across the board started in February 2021. So we have the normal period for years and years up until 2021. Decriminalization of psychedelics and every other substance took place. We have this overlap of time where both of those policies were in place, but in April 1st of 2024, the governor signed into law that they're rolling everything back, at least the measure 110. So we're going back to the same old drug policies. There's still some things being hashed out. And so from April 2024 on, and really we can argue if it should be September when the rollback actually happened. Now we're in just the regulatory phase for psilocybin service centers. So with that in mind, you might think, okay, so Oregon went from nothing to something with the psilocybin service centers. But to complicate things further, every county could opt in or opt out of allowing these. And then within a county could have said, no, we're not going to have these. But then a city within the county could say, yes, we are. within our city, and vice versa. So green are places that opted in. They said, sure, we can have centers here, and red are places that said no. And you see there's green dots in red counties and red dots in green counties. So ideally, we would look at visits all over these and really be able to compare them. So that's just the landscape within Oregon. And again, we anticipate this is going to happen all over the United States. So think of what we're doing here and how we could apply this going forward. So how do we actually measure the events? And you already brought up, these are clinically significant things that we can observe from medical records. So one place we looked was toxicology. So National Poison Data System is great. It integrates data in real time. If you're at home and a kid eats some packet of Tide, they call in, that's going to get recorded the same as if someone shows up to an emergency department and they say, hey, this person had 3 times their dose of Adderall, some Red Bull, because they wanted to code more, but now they're having palpitations. What do I do? Psychedelics, same thing. And this is great because they record each substance, and these could be single ingestions or multiple ingestions, and they record the severity of the outcome. Where was the call coming from? Did they need to go to a healthcare facility? Did they get admitted to the hospital? Did they get discharged? And so on. Prior work has shown that most of the people who the centers receive calls for are young, so 13 to 29, not surprising. And most are discharged. There are some serious events, but they're very infrequent. So we wanted to replicate this and push this out to more recent years. We got data from 2013 to 2022. We looked nationally, and we looked for a few substances. So mushrooms, psilocybin mushrooms have their own code. We also looked at other things because we're concerned about sensitivity and specificity. Someone might call in and say, my friend ate some mushrooms, and that's all I know. So we wanted to track things like this mushrooms unknown, or the plant's hallucinogenic categories, which are these maybe catch-alls for things where the person on the phone isn't exactly sure where to place the substance. So we track these, and here's some of the results for some of the psychedelics. First, you can notice the order of magnitude. We have about 7,000 visits related to psilocybin over this 10-year period. Misha? Sure. So about 7,000 calls related to psilocybin over 10 years. And you can think back to that JAMA article Brian mentioned, where they had 3,500 participants across all these studies with psychedelics. That's the entire sample, where they lump tens or hundreds of studies together. You're getting to 3,500. Here we're having 7,000 calls over the course of 10 years. That's not a lot if you compare to other things like these plants, other toxic, or the mushrooms, NOS, which are those top 2 lines. Those far outweigh the number of calls for psilocybin, which are down here on the bottom. I like these 2 graphs because it's sort of a line with statistics. If you look at that blue line for psilocybin here, if you look, it looks like it's going up a little bit, but nothing compared to the fluctuations, right? Just the fluctuations over time for some of these substances. If we zoom in on this, and this is disaggregated by age category, it looks like a much steeper line. So it's a steep line in the last couple of recent years, but again, in context, what does this mean? I think we need more years of data to really understand this and not worry too much, but also we should pay attention. One other takeaway here is that this is increasing across all age categories. You might think, oh, it was just adolescents or young adults, but there's even an uptick in these greater than 65-year-olds. So we see from our NPDS data, detailed data about the substances, right? We trust the Poison Center. That's exactly what they care about, which substance to use. We can see we can tell a story looking at different age categories, which I think is important if you're thinking from the FDA or policymakers' perspective. Maybe there's a large relative increase, but in context, is that a large absolute change? I think we'll have to follow this a little bit more. Our findings are similar to what others have found. And then a couple of things to know, and this is getting back to, well, what about the people who didn't call in? Right? Tons of people could be at home having something happen and no one thinks to call in to a poison center, or they call someone else. Similarly, what about all the emergency department visits that the ED physician didn't call in related to this? So the calls to poison centers are voluntary. That's just one of the limitations, though. We have to take this with a grain of salt, because the example I like to think of is calls to poison centers for opioids decreased over the last few years. It's not because the harms from opioids decreased. It's because no one needs to call a poison center to deal with it, or much less so now than, say, 10 or 20 years ago. Jumping, though, to focus on emergency department encounters. We look at a couple of different data sets. The first one is this healthcare cost and utilization project. There's a national data set of emergency departments. They also can track people to inpatient visits. We have tried, and I'll explain a little bit about why we can't use it, the National Syndromic Surveillance System. This is great. This is to look at outbreaks, what's happening in close to real time. It's nationwide. We've tried to talk to Oregon also about getting their data. And then within states, we have state-level HCUP and NSSP. And then some work that's been done similar to the HCUP national data set for emergency department visits. There's a data set of California hospitals. People from Stanford, Gorel and Lemke and others recently put out a paper that I'll describe a little bit. This is their finding that they looked at across all these hospitals in California. They looked at ICD codes for hallucinogen-related visits. That's the ICD code. And saw that there's an increase both for emergency department visits and for hospitalizations. It's not super surprising. And one couple of things to point out, though, are there's some slight increase, but it's not an off-the-charts rise. It's not exponential. And the absolute number, right? We talked about 7,000 or so poison center calls over 10 years. Here we have 3,000-4,000 visits per year across California. They're both hospitalizations and emergency department visits. One thing that's a little tricky is that there is some ascertainment bias where more severe cases or people who get admitted, they have a lot more work done to figure out, well, what actually happened. I should point out, as emergency physician, if someone's altered and I think it's due to a substance, I might still just code altered mental status, and no one will ever know what substance they used from looking at the data. Yeah.
Just wondering, so you're right, it's absolute not a large increase, but it's still almost 100%, over 6 years. So, how do you, at what point do you say this is not safe? Like there's always going to be a rate of adverse events, and I'm wondering maybe comparison with the semaglutides, right? We think of those as safe, approved drugs, but there is a risk of bad things happening that we accept as cost of doing business.
Yeah.
So do we have an estimate of what that number is for?
Yeah, what's the threshold? That's a good question. And part of the challenge in this is what's hidden in these ICD codes is we don't know what substance someone even used. So someone could have used any psychedelic, and it might get coded as the same ICD code because they all get lumped together, and you can't figure out what went in there. So I might see someone who used ayahuasca, and then the next patient who used psilocybin, they're going to get the same code. So when we see this increase, we can't really attribute it to psilocybin or any other specific drug. And the other thing is people may just be more willing to share with their physician what they took. So that could be driving this. Physicians may be more aware and say, oh, I know what that substance is, and code it more accurately than before. They just say altered mental status. Now they're putting down a more specific ICD code. So there's a lot of nuances that make it really tough. Nonetheless, we've tried to do the same thing with this. Essentially, that was Californian data. We've done the same thing with national data. And here's what are similar to the other graph where we look across age categories. We can see from 2016 to 2020, that's the most recent data we had available. We do see this increase across age categories. The 6 to 12 and the 0 to 5 are down there at the bottom. But maybe there's an uptick in the 0 to 5, right? Maybe, do we even care not just the number or the rate, but what about specific to populations we think maybe shouldn't ever, right? What's the threshold for a 20-year-old versus a 2-year-old? So we identified these using the ICD codes, knowing those limitations, to say, well, at least we can track something. We have to measure something and see what the trends are here. We also found these encounters aren't that common. We get about 73,000 per year in this HCUP data set, which is similar pattern to what we saw in the HCI data and the NPDS. But I mentioned these things are not specific to substance. It's not sensitive because I might just be saying this person is psychotic or altered, and we don't know what actually contributed to it. And then the other part that's tricky using this data is there's a lag in the data availability. It takes HCUP about 2 years to get data out. Misha?
Yeah, question from Dr. Weingarten in the chat. Is there any evidence for anticipatory adverse events versus positive beneficial events?
Evidence for anticipatory adverse events versus positive benefits?
Can you explain what that means, actually?
Yeah. Can you ask them to clarify a little bit? But I should, as you're doing that, I'll point out that we're not tracking benefits. That's something that maybe we're doing on the side because we're not, we're already too busy, but we're deciding to look at other things. So one of the things we're looking at, for example, is the association between psychedelic use and opioid use disorder. There's been some signals in the past, and we're looking into it with more current data. Okay. Just feel free to interrupt and ask again. Yeah, Josh?
Is there a way to know whether there's certain mental health pre-existing conditions?
So no, but this is what we'll get to. So that's a good, perfect question if you're a plant, because so we want to look over a specific time and place, so that's where we get to Oregon. And I'll get back to that in a second when we talk about the Oregon data. Briefly, though, we'll think about how many people have used, because back to the question, well, what's the threshold? One in what? Well, what's the denominator there? We're trying to estimate how many people have used a substance. So what we turn to for that is the National Survey on Drug Use and Health. They sample about 55,000 people a year. It's a repeated cross-sectional survey, so every year it's a new 55,000 people. They're strategically sampled and there's weights, so we get a nationally representative sample. They lump these together as hallucinogens. That's their terminology here. And I'll point out one thing here is they ask lifetime use of psilocybin, but not past year use. So when we're looking at the associations for psilocybin, what typically is reported in literature using this survey is just lifetime use. And here's a quote from one of the papers. They say, well, one of our limitations is we couldn't examine past year use of psilocybin. Here's some results from RAND where they've looked at some lifetime versus past year use. Of course, lifetime is much more, but there's still significant past year use. There's a percent of adults in 2023. So keep this in mind, 3% or so of adults used psilocybin in the past year, compared to maybe 13, 15% ever. We get pretty similar numbers when we look at, this is lifetime use. hallucinogens are all lumped together at the top line, and then the specific substances are broken down here. But I'll jump to looking at, these are age categories over time for specific substances, and this is new past year use. So that lifetime use and past year use, we thought, well, if you're a policymaker, what do I care if someone used something 20 years ago? What does that have to do with the law changing now? And if you think about people who, if you just very, very simply lump people together into they've ever used a psychedelic or never have used a psychedelic. If policy changes, the group of people who have used may use more frequently, or a different substance within the category. If you take the other group, they've never used anything, so it's going from 0 to 1 or more use. And I think from a policy perspective, you're kind of interested in that second group a bit more, right? It's a much bigger group, right? 85% of the population, and potentially is more risk of harm if they're just trying this and maybe don't have the right support or right mindset going into this. So we look at new past year use, and by that we mean among people who've never used psychedelic or hallucinogen in the NSDIC categories. We see some trends for LSD. MDMA, I didn't realize until we got this, is really dropping off. It was pretty surprising, to me at least. But here's psilocybin, and you say, well, we just said we can't get past year psilocybin. What we did was we combined the question for what was the first year you ever used a psychedelic? If it was in the past year, and you also said, yes, I've used psilocybin, we put those together. So this is the first reports using NSDA where we're actually reporting new past year use. So kind of like with the NPDS data, we see this trend up in the last couple of years. 2020 is an anomaly because of COVID. Their sampling methods were all over the place. And so just like with the NPDS, they say it looks like a trend upward, but we have to see what happens in the next couple of years.
And Juan Carlos, just maybe one thing for that slide with the trend is that our guess is that this is a minority of people that use psilocybin in the last year, right? We're not trying to say like this is a index for last year users of all of them, but if this is the only thing we can capture so far for last year use using this data set, and one of our big problems is what can we understand already from the data sets that the government's already paying for, that's already being produced, what can we actually learn? This is the best we could do for psilocybin so far, and thankfully, because of some of those conversations that folks at SAMHSA and others, like we mentioned earlier, were having over the last few years, in 2025, and the data they can collect now, they're going to start asking past year use of psilocybin directly, and so we'll have a better measure of that moving forward.
Yeah, and Misha?
Yeah, question from the chat. Do any data sets being used allow for verification of rescue medication use, like benzo or atypical antipsychotics for psychological distress, others for HTN, and can that be used as a proxy of age and severity?
I don't know of that in any of these data sets, but that's what we're going for with this next set. This is the one where we're trying to get into what actually happens with these hospital visits, these emergency department visits. So not in those existing data sets, but because there's so many unanswered questions, right? We get these ICD codes, and we don't even know what substance someone used. We don't know why they went to the emergency department. Did they go because they went on a hike and they actually had a small dose and they twisted their ankle, but then the doctor charted it as well as one of their co-diagnoses? So we wanted to dig in and do a deep dive into some patient charts. We partnered with 3 organizations in Oregon, so Kaiser, Legacy Health, and OHSU. And we said, well, let's look at their data for the last several years and also request some quarterly pushes going forward. And so what we wanted to do is twofold. One is just describe those visits, because we have the bird's eye view of these visits happen, but we actually need to understand what happens in those visits with the rescue medicines, why were they even in the emergency department, and so on. And the other aim is to look at, well, we have granular data. We know to the minute when someone showed up to the emergency department. what can we say about when people showed up vis-a-vis the policy changes at that local level, where we have the state making the change, but you saw that map with the counties and cities making their own changes over time. And we can see when a psilocybin service center went live in a given location. So we expanded the definition. I'll spend a second on this because we try to have a very inclusive definition of why someone could have shown up. So there's the hallucinogen-related visits. Those are easy. These F16 and that second line, the T40, 40.9, 43.64. But then we also included these other diagnoses that generally do not indicate a given substance, psychedelic or not. They just say some other psychoactive, so at F19, or unspecified psychosis, which oftentimes may say not due to the substance, even if it is. That's a whole other topic. But we wanted to cast a wide net because we knew we'd be able to get into the patient records and read in there and say, well, was this one of our substances of interest or not? We also asked for a lot of data because we basically said, dump the entire chart, whatever you can abstract from it, dump it into a secure file, share it with us. So we're getting the usual things like age and race. We're looking at comorbidities, and places like Kaiser, that's great because if you're a Kaiser patient and you show it to the emergency department, they know what's wrong with you from the past. We asked them for what medications did this person receive when they showed up. Was it the antihypertensive because they're having something that was more sympathomimetic effect? Or was this a benzo because they wanted to have their mind slow down? Or what is the practice, right? You might have an argument about, is this benzodiazepines or is it antipsychotics that you should give someone? So we're looking into this. We're looking at what medicines were given, but also what tests were done. Did people get non-contrast head CTs to look at, is there something structurally going on in the brain versus metabolic panels or what? Where did they go when they got discharged? Did they get admitted? Did they go to the ICU? Did they go home? Did they go to psych emergency? And a lot of this is in this HPI and MDM section. So exactly what the doctor or nurse practitioner wrote, that's what we're getting. And so yeah, that free text portion is a lot of what we're combing through. And I mentioned we have these diagnoses, these that I mentioned are not specific, the F19, F29, and T62. The other ones we feel confident. These represent some sort of relevant substance. We'll look into the chart and see what the substance that they actually recorded was. But we said, let's include these F19, F29, T62 codes, and we'll comb through them and see, did they mention psilocybin? Did they mention ayahuasca? Right? Did they mention some psychedelic term, MDMA, whatever? We have a whole list that we're combing through. And of those, if it includes a positive search term, then we're including them in our cohort. So we have sort of two sub-cohorts within our cohort. This is very preliminary results from one of our partners. So for a few years of data, for 2016 to 2024, the core codes, meaning the people we believe this is what we're looking for, there's 67 cases. So it's not that many, right? We've been talking about orders of magnitude bigger. And then you look at the peripheral code that we knew would be really nonspecific. We have 2,394 of those. There's a little bit of overlap, but interestingly, there's not much overlap between the primary and the core and the peripheral codes. Of those 2,394, once we went through and matched based on the terms, ayahuasca, MDMA, psilocybin, this whole list, we found that only about 10%, 258, were positive. So 90% of these probably are unrelated to a psychedelic. And then the other 10%, maybe they are related. Right? This is preliminary, so we need to go in and say, well, was it even related to that visit, or this is just something they mentioned in passing? At least they passed the first screen, though, that these words were mentioned somewhere in the chart. Here's some descriptive statistics from those results, the core results. I'll skip over a lot, but just point out one thing. We're still figuring this out, where we wanted, for example, gender and sex data. We have a lot of missing data. Oh, shoot, it got cut off. Well, the sex and gender data, it looks like this institution collected one and not the other. So part of what we're doing is collecting data from all our partners, and then we're combining it. In fact, that's what our call this afternoon was. How are we going to consolidate all these different data sets, since they're all recorded slightly differently? So we're working our way through that. And one thing I should mention also, we do have, here's a little bit of data on the comorbidities that people had. So including their psychiatric disorders and other medical comorbidities. That's what the Elix-Hauser score combines. It basically ranks hypertension, heart disease, diabetes, whatever, and you can change that into a number just to get a sense of how sick is someone at baseline. So what we're doing is characterizing their chief complaints. Why did they even show up to the emergency department? What about the patient characteristics? What are the diagnoses? Not just the diagnosis code that got them into the data set, but what are the other diagnoses associated with this visit? Right? Again, was it that sprained ankle? Was it psychosis? Oh no, I don't want to register. And this graph right here is a representative graph of what we're hoping for. I love this figure because this is exactly what we're envisioning, where these are pediatric visits to emergency departments in Canada. There's two phases. First, when cannabis was legalized, and then when edibles were legalized. And so you see the slope is pretty flat, then you see it rise, and then when edibles show up, then of course pediatric visits really shoot up. We don't know what our graph is going to look like. Right? We're still collecting the data. We're harmonizing it across the three data sets. But eventually, this is what we'll be looking at for that AIM-2 of in places where the law was changed, do we see a before and after? And I showed you those, the baseline, 110, 110 and 109, and then just 109, those different phases. We'll see what happens with this over time.
Maybe just a couple comments. Thinking back to, we have the core codes, the peripheral codes, these pretty small absolute numbers of cases, right? We're not trying to say like we're finding all these cases or that's the outcome here, but we do want to understand if we're going to measure it, what does it actually mean? What does it actually look like? And then how do you translate that into emergency department evaluations in California, in Colorado? The finding of, if you just use the ICD-10 codes that people use in prior studies, maybe you're going to see like 1/4 of the people that are actually coming in. So like if you use that method, try to understand the sensitivity is going to be really poor, but no one's ever done that sort of evaluation. And so that's why we're digging deep into these charts for our collaborators in Oregon, which, I'm glad we have the data at all. I don't know if anyone in the room is a health service investigator, but one of our senior partners in Oregon has done a lot of work, funded by NIDA and others doing health services, kind of laughed and said, no, the IRB is never going to let us send you the charts of our patients at that level of detail. But 2 years later, all the data use agreements and the contracts and everything, we have this like pretty precious data set that we're going through to try to say, even if we develop an estimate of confidence on the sensitivity and specificity in this pre-policy and now maybe in a more enriched post-policy Oregon, that can help us interpret how we use these analyses in other parts of the country. That's kind of one of the sort of like the big pictures, what we're trying to get at here.
Quick question, it's not that quick. How do you know when it's bad, right? Like, of course, when you increase the exposure, you should expect to see more of that showing up everywhere, right? Do you have an idea? Like, so there's been some like foundational work with cannabis where they did lots of these big closed claim sets. I don't really know the details, but they discovered that exposure is seems like a well-founded result. It's based on a large data set, and that's like a risk that you can sort of estimate. And I'm wondering where, do you have an idea of like what the shape of this is going to look like in terms of like what's your over-under for, this is a public health issue that should be addressed versus this is actually, wow, the rollout is going pretty smoothly.
Yeah. I mean, there was a slide we had up there with some yellow print that was there a couple times where we tried to lay out 3 important steps. What's the policy change? What is the incident of bad things, adverse events, and how many people are actually using? So what I want to be able to say is when this policy change happens, we may have more adverse events, but that is outpaced because there's many more people using, meaning like the per user rate of adverse events is going down because we have better systems and people are more used to it. Or no, the use is going up a little bit, but because the people who are increasing are now teenagers and other people without support, the rate of adverse events is actually going up much worse. That's like a calculus problem, and I haven't done that math for a while, but that's what we actually need to try to figure out. And that's what we're getting at, is that if you want real measures of how many people are using, in what location, and the rate of adverse events, that for me is a more meaningful way of looking at what's going on. And no one can tell us that right now, but we're trying to bring those puzzle pieces together.
Yeah, we're patching it together so to at least get a back of the envelope estimate. And right now, I would say, I think we had about 73,000 visits per year in our HCUP data, nationwide emergency department visits with one of these relevant codes. Again, we don't know what substance was related, but it's in the hallucinogen ICD code. And then looking at the NISDA data, the national survey, about 7 to 8 million people used psilocybin last year. I don't know if the data in the EDs reflects psilocybin versus other substances. If the trends both go up, maybe we can guess that they travel together. So of course there are a lot of other substances that people could have used, and a given person may have used once. In the checkout box in the NISDA, they could have used something once. They could have microdosed 80 times in that year, and we can't observe that. So we can't even observe the per use risk. We can just say, out of this many people who said they used something in 2023, from this survey, 7 to 8 million, we can say that 73,000 ended up in the emergency department, may be related to that. But that's where the OHI, the Oregon Healthcare Institution's data, will hopefully help inform that. So we can say, well, maybe 20 to 30% of these ICD codes represent psilocybin. We won't know because it's Oregon, but at least within Oregon, we'll have a sense what that looked like.
I think we're at an hour, so we should wrap up soon.